This was a brand new school. They're not going to let anyone fail. They had a very hard limit. You had to get 70% or better on comp, and she got 66. Boy, if you're coming from a Caribbean school and you fail step one, I can't help you. You've dug yourself a hole. No residency director in the United States is going to give you a fair hearing. You just can't. And you can imagine there was lots of tears and anger on her part. It's not just that she knew it all. It's that it hurts your pride. It's a whole nother semester of tuition. This is tens of thousands of dollars. And you're going to lose how many months? And I said to her, how do you think in 40 years, you're going to remember that you took another 3 months and used it to get to a place where exams are easy, not squeaking through? So I said to her, I would hire you in a second. I would want you to be my doctor 2 years from now. So let go of your embarrassment. No one goes into this game because they want to make money. We do this because it's who we are. And don't you want to be better? Don't you think these people wished you well? And she accepted that. What a lovely person. She just got it. She got over her feelings. She said, good, I'm going to use this to be really good. And this is when I found out, because I teach everything by visual, she said, I can't do it. And I just stared and go, well, I don't know what to say now, because that's how I do everything, right? Well, it turns out, you know what she does instead that is extremely effective?
Dr. Tisdall, you are at your medical school right now this week, teaching live in front of students. Tell me what's going on. What's the update?
So this is a new med school. It's only 5 years old, and they've gone through their first round of at least getting something out there, right? Let's not worry. We got to meet compliance. So they've been through their pioneer experience, and now they're sort of struggling. Are we startup now, or are we early mature? Like they talk about that because they're trying to figure it out because it was such a wild woolly west when they were starting out. In my mind, I think they're through the first round. They've got everything is filled. They've got approvals for all the things that matter. They're credentialed. They graduated their first class. So I think they're past startup. And so it means they're changing over their personnel, right? These are the farmers that followed all the people that hunted and trapped furs in this area, right? Now we're getting the plodding farmer types. And they've got a new dean. And I got to tell you, I kind of came for the dean because she's a no-nonsense pediatrician for many years, and she's got a vision, which is we're not teaching subjects, we're teaching doctors. Well, yeah, talk about singing to my choir. And I really like her a lot. And she should be dean, not me. I mean, she's such a lovely person. But boy, talk about the velvet glove over the steel fist. So, it isn't like she doesn't intimidate me a little bit. But I do, we haven't tested it yet. But I do feel I have her backing when I start pushing for patient-centered learning. And so I'm here. It's what's so extraordinary about this job. And the students out there need to understand this. I'm only here 1 week every couple of months live. This is the new world. This school has made the decision they would rather have excellent teachers, mostly remote, than the mediocre people they would get who are willing to come to a small town in southern Utah. So it's interesting. All my fellow teachers are the same thing. They're all national caliber people that the students would know if they'd ever done a review course because these are the people. It's really interesting. So the strength of the teachers is remarkable. But then, of course, everyone's very confident that they know the right answer. So it doesn't make negotiation very easy. So I've mostly been teaching online. It's been a very positive experience. And what the students should think through that are out there listening to this is, the students here, real time, they study in groups, they study individually, and they ping me with a question. And if it's during the day, I'm usually at my computer because there's lots to do and I really like it. And so I will immediately ping back free ? And if they say yes, I just push the video button. It's magic. Now, if they've met me, it's a different online experience than if you haven't. So if you've just meeting me as a stranger, I'm kind of an avatar. But if you spent hours with me teaching, it's like you and me talking. I've met you so much in person. This is 95% of being with you. And so as I'm more and more in person here, these remote calls are more and more quality. But no matter what you say, for you to be able to ping me real time and get a real time answer is truly impressive. And we need to talk about how better to use this technology.
Well, we're certainly going to be doing it in our new community that we're working on.
Correct. No, that's exactly what we're exploring. And no one should have a strong opinion about the right way to do this. This is all brand new. We should try it. And if it's good or not, let's talk.
Community 1.0, like any of you who are in there, it has a ton of resources. But what Community 2.0 is going to change is that they will have access to you. You can actually go in, answer the questions. You're going to be going live in the app. It's very close to what you're talking about, teaching at a medical school.
When we come and talk about what the experience is going to be for the student, this is what happened last week. Last week, a student pinged me and said, so when the ascending aorta dilates, does that cause the degeneration? And it was just so fundamentally in the wrong order. I didn't answer a question. I just said, free question mark. And we spent 35, 40 minutes talking about the pathology of the ascending aorta, which is cystic medial degeneration, and how that's unrelated to the abdominal aorta, which is atherosclerosis, and why it matters clinically. It was not just a chance for her to fix a deeply flawed idea. She got a chance to start learning how to use medicine. I mean, I use medicine to teach learning medicine. Okay, so that's what real-time fixing it. She was sitting there in a coffee shop of all things, and she was just really went, does that make sense? Absolutely not. Let's just talk for half an hour and get this whole idea of pathology. And she had to learn this idea. Pathology starts normal and progresses across a degenerative timeline till it's severe enough you get a symptom. And if you want to interrupt it before it gets a symptom, that's called screening. So, we were talking about, is it worth screening hypertensive old males? Short answer, no. Is it worth screening smokers for abdominal aortic aneurysm? Short answer, yes. Well, who would you screen for ascending aortic aneurysms? Well, Marfan's, if you have an inherited disease. For her, it was just learning to think in medicine, real time, when she needed it, right then. It was just really fun to do. And you can see how we're going to do this in the community, right? We're going to have open mic periods. And you can just call in with things that have been bugging you, and I'll just wing it. Let's compare that to live in person. I have this lovely, what they call here, a pod. It's a group of students who study together. And I've had a couple of other interactions for them. And that matters because they did that in exam prep, and they went to their exams, and guess what? Oh yeah, their exams went way better. So they not only enjoy the experience, they absolutely know it works. So they were just waiting, dancing in their slippers for me to come this time. And we talked yesterday. And we talked for, it must have been an hour and a half. But this was the difference in the experience, Allie. They happened to be in cardiovascular. So we were doing the vasculitides. And I didn't think much of it. They're the vasculitides, very orderly, large elastic, medium muscular, small arteries, 2 for each. What could be easier? Wow, they had this garbled set of jumbled facts with no order. And I kept looking at them. Why would you learn it that way? And so I just took the time. Someone stood at the blackboard, and I just beat on them. Okay, let's start with giant cell arteritis. When you have a disease, it's presentation, pathophys, natural history. You would think that's straightforward. Well, it is when you've been in practice 40 years and taught for 12. What's the biggest problem in medicine? What kind of first or second year medical student know? They don't have that order in their brain. I can't tell you. We did all 8 disease, and it wasn't until the 8th disease they knew I was going to say presentation is symptoms, signs, and testing. You would think that's a straightforward idea. I mean, it's easy if you've been doing it a long time. It isn't. They keep confusing pain and tenderness. One's a symptom, one's a sign. They couldn't understand why in a systemic inflammatory disease, the patients feel unwell for weeks before they get symptoms. So we had to sit down and map out this deep understanding of pathophys. We got to work on this idea of presentation is who walks in the door. Yeah, they kept wanting to start with, this symptom. I kept, no, you start with age, gender, time frame. See your patient? Good. Let's walk through now. What is that symptom? Is it a chief complaint? Oh, now you got a differential. Good. Tell me about a directed, these are obvious ideas for us. And you can read chapter 1 and they're in chapter 1. That's not the same as someone saying to you, why are you going there? Don't. And so physical exam is directed. It says rule in and rule out for your chief complaint. It was genuinely fun. Lots of laughter. They fully understood they were being organized by me. Everyone's allowed to be wrong. It's really funny. It was the happiest, merriest hour and a half I've spent in a long time. And you know what they could do at the end of it? Presentation, pathophys, natural friggin' history. And it was, you couldn't have done that remotely because there was so much body language. There was so much of me jumping on my chair and going, well, you haven't got the annulus fibrosis. Here, start here. Got it. Then they're watching, you don't have to be taught many times. It turns out you do have to be taught once. So now I can't wait to see how well they go on their exam next week. Because I promise you, they can do vasculitis as well as me now because I taught them everything I know and they're perfectly smart people. So I got nothing left to teach them. Boy, the deep ideas, the vocabulary. Here's an idea that's surprisingly subtle. Sometimes you start with pathophys because it explains all your symptoms. Sometimes you start with your symptoms because it lends itself so well to explaining the pathophys. You'll find I often flip on that. I never know which one to start with because they both have advantages. It was fun to talk about. You don't have to feel, it's not rigid. This is not a Procrustean bed. What makes this story go best? And there are lots of nuances, right? Here's a good example. We're doing Kawasaki's disease. Boy, I mistaught that for years because it starts with a 2 to 5-year-old child presents with 5 days of high fever. That's it. Don't want to hear anything else. Well, everyone's throwing out rashes and, strawberry tongue, it's such a vivid image. Everyone's throwing out these things, and I'm going, absolutely not. Well, it turned out we had to discuss what do we mean by clinical diagnosis. They just literally didn't know that. A clinical diagnosis is a diagnosis that's established by the history and physical. No testing. So it was just, what a deep idea. It was so obvious to me. They kept wanting to do a test. I go, no, it's a clinical diagnosis. But I was there watching them. And finally, by the second I turned time, I said, no, it's a clinical diagnosis. And I started to get these. It was clear they didn't have that idea. But I couldn't have done that if I hadn't been watching body language.
And it also goes to tell you the power of having a clinician, someone with clinical patient experience teaching medical education. There's a place for PhDs, but they have not seen the patient. They have not gone through what you're talking about.
This is how extraordinary it is. Every medical student in the whole world can tell me perfectly what rheumatic fever is. And if you give them a little nudge, they can differentiate acute rheumatic fever from its complications. So suddenly we're talking about clinical diagnoses, and I said, rheumatic fever is really important. It was the first world disease in which every institution agreed these are the criteria for clinical diagnosis. So for me, it was one of these beats you over the head. This is brilliant. This is our future. So we didn't miss that point. And so I just said, so what are they? Now understand, they've studied rheumatic fever. They know it perfectly. And they gave me this blank look. And I looked at them and said, how could you not know this? And they gave me the look, well, I wish I did. I can't. I have nothing. And I looked at them, and just out of the blue, I said, the Jones criteria. And they went, they knew those perfectly. Okay. I don't know. I don't even know what to say to that. What do you think they were learning them for? They were learning them because they were written on a board and said, you will learn this. It never crossed their mind that someone would come in and you'd say, in my differential is acute rheumatic fever. It's a clinical diagnosis. There are 5 major criteria, and I'm going to do a directed examination to see if I can have 2 of those majors, because that establishes the clinical diagnosis. Well, they were just like, well, that's way better. Yes, that's why people loved it.
So what I'm hearing is that the why of what you're learning is just as important as the what, if not more.
Yes, because if you've memorized something out of context, unless I ask you in that context, you can't retrieve it. But if I say to you, I've got a sick little kid in a resource-poor nation, and you hear a murmur, absolutely, you're going to put fever, murmur. You're going to put acute rheumatic fever. You go, so where do you go from here, doctor? It's tell me the pathophys. This is a systemic autoimmune disease, post-streptococcal innocent bystander damage to the heart with systemic manifestations, diagnosed by 5 clinical criteria. That's the pathophys, right? Now if you say, well, I get it. Tell me the 5, I have a context. But if you just throw the Jones criteria, they were just astounded. They were, well, if that's all you want, don't give me that's all you wanted. You had nothing when I gave you a sick little kid. Don't tell me you knew that because you didn't have it when you needed it clinically.
Well, one of the big themes you talk about in your videos is how to organize the information you're learning in medical school into frameworks where you can actually remember it and actually understand it and apply it. So whether it's an algorithm, a table, or a picture with a story. And we had a viewer that asked a really interesting question that I think you can answer well. And it's the concept of a picture with a story. Can you draw it in your mind's eye? But there are people who can't hold that picture in their mind. I think the condition is called aphantasia. And as I understand it, you had a student with this issue.
So this was one of the most lovely students I ever had, and she and I were together for a year and a half. And I would adopt her if she didn't like her father so much. And she came, and she was right in the gray zone. When you go to most schools, especially the for-profit schools, the way they can say 95% pass rate on step 1 is they give you a comp exam to make sure you can pass it. Everyone that's close, man, you weed them out. And it's enormously important in advertising for the school. Who's going to go to a school where half the students fail? So you die with your step 1 pass rate. The ugly secret is, yeah, you can pass it because we don't let you write it unless we're sure. So this was a brand new school. This is their inaugural class. They're not going to let anyone fail. And so they had a very hard limit, lots of tears and crying. It was a very hard limit. You had to get 70% or better on comp, and she got 66. And it wasn't that she didn't know everything. She lectured me on all sorts of molecular things that I didn't know. And I was in the school meeting when they talked about that 60%. It was agonizing. We all recognized what a quality person she was. We all knew odds were she would pass. But boy, if you're coming from a Caribbean school and you fail step 1, I can't help you. You've dug yourself a hole. No residency director in the United States is going to give you a fair hearing. You just can't. So make sure, if I could have the single most valuable thing in the world, it would be to be able to give a student a test that would say, you have a 99% chance of passing step 1. I would own the world. Every time I work with someone on question banks, they go, I want that test. I go, well, stand in line. I mean, we all want that test. But it turns out the comp exam is pretty good for that. And so in terrible, agonizing discussion, they said no. And you can imagine there was lots of tears and anger on her part. It's not just that she knew it all. It's that it hurts your pride. It's a whole nother semester of tuition. This is tens of thousands of dollars. And you're going to lose how many months? And she came into me pretty upset, And I said to her, how do you think in 40 years you're going to remember that you took another 3 months and used it to get to a place where exams are easy, not squeaking through? How is this going to matter in your decades of career? Because first I'd say, you're a wonderful student. When you ask me, so I've been asked to interview this school. I just hate interviewing, but they've asked me to be, because it's really burdensome, right? Everyone's so nervous. It's so unpredictable. I get it, but they've got to do it. It's part of the experience. So I have to get trained at it. It's like, everything about this is difficult. But, in my secret soul, not all the forms I'm filling out for compliance, in my secret soul, when I interview you, I'm going to ask you 2 questions. Would I want you as my doctor? Would I hire you as my partner? And if you make me twitch on either, boy, So you can imagine how comprehensive it is. Do I get a sense from you I could train you and trust you to take my place for 2 weeks? That's a really tough judgment of a person. So I said to her, I would hire you in a second. I would want you to be my doctor 2 years from now. So let go of your embarrassment. Money is money. You'll always have more. You'll always have left. No one goes into this game because they want to make money. There's way better ways of doing it than starting with $400,000 debt. Trust me. We do this because it's who we are. And don't you want to be better? Don't you think these people wished you well? Don't you think it was you that we were thinking about? Because I said, you can like it or lump it, Alyssa. It was 66. That wasn't unfair. And so we started, and she accepted that. What a lovely person. She just got it. She got over her feelings. She says, good, I'm going to use this to be really good. So we started working really closely together. And this is when I found out, because I teach everything by visual picture, she said, I can't do it. And I just stared and go, well, I don't know what to say now, because that's how I do everything, right? Well, it turns out, you know what she does instead that is extremely effective? She takes every picture with a story, and she turns every story into a computer script, if then. So when you break down a story, stories are always, well, Little Red Riding Hood decided to see her grandmother as she's going through the wood. And so for me, I would show a little girl with a red cape going through a wood. You go, oh, I love that story. She took them and did the words as a computer algorithm. Little girl with red cape starts trip. Next line, big bad wolf meets little girl. It worked great.
Can you think of any actual examples that pertain to learning medicine that she would have done where you would have used the picture and this is how she kind of broke it?
It works really well for chief complaints. Find chief complaint. See differential. How would you rule in? How would you rule out? Because it's very orderly the way we do it, right? What is the symptom? What is the sign? What test? Testing teaches pathophys. How does this fit into pathophys? Sarcoidosis is a systemic autogranulomatous disease that involves our organs, but typically expresses in mediastinal lymph nodes and lung. Well, if you can do words, you can do that. Right.
So how does that differ from an algorithm, or is that an algorithm?
It is an algorithm. It is an algorithm. She does everything as an algorithm. I mean, I think there's certain areas that's pretty ineffective. And I really am looking forward to how well she does when she has to do imaging. So she has to do CT scans and MRIs. I'm really looking forward to how that goes. But she took those months to be so good that I told her, I want her to come and teach for us. That's how good she is. She's the best. And she will come and interview. We've got to interview her. Everyone will fall in love with her. And she's going to be wonderful. But it was quite shocking to me when I wasn't allowed to use pictures with stories.
Well, we did get another question as well. And we have done a full video on structure function, but I think these concepts are so important when learning medicine that we might as well revisit it again. And basically he said, hey, can you make a short video on the key structure function tools we need to know for every major branch of pathology? And he gave the example of echo for cardiology. Before we kind of answer that question, what I'd ask is, why do you think students even struggle with this in the first place?
So in the first place I taught, it was a traditional medical school that taught through systems. And I didn't get students until fourth semester. But in third semester, we started with general pathology. And third semester was microbiology, physiology, and the start of pathologic principles. Perfectly fair. And remember, this is a Caribbean school, so by definition, everyone is a poor exam taker. And almost every student failed one of those three. You failed microbiology because you couldn't memorize. You failed physiology because you weren't a mechanical engineer at heart. And you failed pathology because the answer is, it depends. And so, the people who hated pathology the most, I had an engineer sort of come in and yell at me. Tell me the criteria and I'll set the process. And I looked at him and said, well, it just doesn't work that way. Every situation is looked at this way. This is the best way to look at this situation. So your student is quite right. He recognized that lack of consistency. He's absolutely correct in that observation. That's why we organize everything through a chief complaint. Then you say, what's my differential? So when I say, let's do shortness of breath will be fine. If your shortness of breath, it's heart-lung. Which pathophysiologic family are we in heart? left ventricular congestive heart failure. Flip up in your mind. How do I think of pathophysiology? Right? It might be an algorithm. It might be from a table. Hopefully, it'll be this really great picture with a story. It just depends. Where are we? Right? But if you said, no, I'm in lung and there's a fever, yeah, it's all imaging. It's not pulmonary function testing. If it's shortness of breath, no fever, outpatient, oh, it's all pulmonary function testing. It depends. And so that's why you have to take the 55 chief complaints and you have to practice them until you've internalized it. And it turns out that's 90% of your pathophysiology. And in doing that, not only will you say, well, where am I? What do I need? Flip up, I need here. Not only that, you will also have learned how to learn. So you'll come to a new disease. You're in the eye. I don't teach eye. You come to the eye, you'll say, well, what do I need to understand this? How do I teach myself? There's got to be a way of thinking about this. How do really experienced clinicians organize their thinking on this? So the answer is that's a good observation, and you're right. That's why you need someone to teach you. That's why you can't teach yourself medicine, right? Because you need that small group intensive tutoring so you recognize, where am I? What's needed here? So yesterday I was with another group, and I said to this very nice group of people, I said to one girl, what worries you the most out of a cardiopulmonary heart? She goes, man, I just can't do valves. I just don't get it. Valves? How could valves be hard? Well, okay, great. How do I think about valves? Well, it's a table. Believe it or not, this is a table. And the table is, and this is what shocked her, well, there's only two valves that matter, and they're stenotic or they're regurgitant. So there's only two. We only do left side. She said, well, wait, what about the right side? I went, there's no story there. They're just little facts, right? You're not going to damage your right-sided valve unless you're injecting IV drugs. So can we just take that off the table? It's just a factoid. We have to do mitral stenosis, mitral regurg, aortic stenosis, aortic regurg, and now we walk across, right? What is the etiology? What is the pathology? What is the physical exam? What is the natural history? And do any of them have unique symptoms? And I just sat there and walked them across it. Well, all of a sudden, first right out of the box, they didn't know the difference between etiology and pathophysiology. Well, it's actually a funny idea. Etiology is the exact cause of a disease. Pathophysiology is the breakdown process in the body. So, for example, supposing we'll do this when we get to congenital heart. Supposing we are doing a little cyanotic baby. Number one cause is going to be tetralogy of Fallot. Well, the etiology is chromosomal. It's a 22q11ds chromosomal abnormality. That's an etiology. But the pathology is embryologic development that's bad through here. So it's not just the great vessels of the heart that have a problem. They have funny faces, their parathyroids don't develop, their thymus doesn't develop, right? So an etiology then has a pathophysiology. And then you say, great, so when we're doing all these valves, we're doing auscultation. And so I'm doing S1, S2, S3, and I'm drawing the little squiggle for what you hear. Well, this is what surprised them. I said, you don't just draw it, you say it. Because it's a sound. So when you're doing aortic stenosis, no kidding, this is what I do in my mind. Lub dup, that's S1, S2, lub dup. Now here's aortic stenosis. Lub pshu dup. Lub pshu dup. Now the words for that is crescendo, decrescendo, systolic murmur. Great words. Do you have a picture? Well, it turns out it's kind of this, right? It's a sound graph. Yeah, so we've spent 30 minutes doing that. And I went, well, that's it. I'm done. Yeah, well, they were done too. Now they can go learn that table. So when your student says, tell me what I need, it depends. And that's why you need tutoring. That's what we're going to bring. We're going to teach you how to learn this area, and we've put enough of them together. You'll be able to go to a new area and know, I've got to look for how medicine sees this.
So when you're talking about disease in general, where does structure function actually sit in the whole diagnostic framework?
Well, it's normal, and then pathology breaks it. So how do you not start with normal?
That makes sense.
When you say to me, how do you think about histology? I can promise you, I'd been through med school, I'd had a fantastic internship, and I'd done 3 years of lab medicine. Never fully been on the microscope like surgical pathology, done lots of hematology. And then I started my anatomic pathology, where it's full-time microscope histology. I couldn't do normal for at least a year. That's something you have to be taught. And then you say, well, what are you being taught? It is, you have a way of saying, this is liver. In my mind, I have, how do I see liver at low power and high power? And then you'd give me a slide and I could compare them. So if you said to me, how do you see liver? I would look at my picture of normal and I would draw it as a cartoon. You should not ever show students the true microscopic pictures. It's hopeless. It took me a year before I was poor at it, right? What you should teach, that doesn't mean you don't need histology. It's a structure function necessity. What you really want to say is, what's the cartoon in your head? I don't need to do it in real life. That takes real expertise and training. But I do need to know, what is the template you're comparing every photomicrograph to? So when you say to me, how do you think about it? I say to you, well, structure function of kidney. Yeah, you got to have a cross-section of the kidney so you can do the pyramid. You've got to have a nephron. And then you've got to have an electron microscope of the filtration unit. So if you can do those 3 things, that's my structure function kidney. Once you give me the nephron, it turns out what makes kidney so tricky, you think, oh, the nephron. It's not. It's like 5 separate segments, and they all have their own rules. So it turns out it's not a nephron. It's 5 pieces of a nephron. And generally speaking, it's so overtaught that the students end up with nothing. Right? You only teach the clinically necessary parts of each segment in broad rules. So, for example, okay, I've gone through proximal convoluted. Yeah, it sucks everything back. That's it. I call it, it's the heavy lifter. That's it. How do you want to break it down further? But each segment you can go through and say, what happens here? Yeah, it's the heavy lifter. Thick ascending limb. Yeah, it creates the osmotic gradient. This, the convoluted, has this little nice sodium chloride exchanger, important for thiazides, right? So I just have a little story for each segment. Oh, those poor students, they study them for days and days and days and can't do a thing. So what do you need? Answer, it depends.
Well, I know a lot of your followers are really keen to get into this new community. I know it is coming. I promise it's coming. We'll get full access to Dr. Tisdall. I think you're going to be in there a lot of the day.
It is so much fun. I mean, I got note, I have to write some multiple choice questions. And I actually, frankly, felt a little resentful. Because I want to find a group, and I just walk into a group and go, so what are you learning? Why are you doing that?
And Dr. Tisdall, you were very specific about the quality of these questions. Do you want to talk a little bit about that?
So medical students love multiple choice questions. I've given up. I've surrendered. It's wrong, but I lose. I get it. I'm going to cheerfully lose here. You should have a blank piece of paper and write down what's in your mind's eye. That's the right way to do it. I lose. I get it. Be gracious. So, when I have to do a review course for the step 1, and obviously you get 42 hours. How can I do anything meaningful when I have 42 hours after 2 years? I mean, get real. Oh, find the high yield facts. Okay, there aren't any high yield facts. So let's just stop that, right? But I said, but there are high yield ideas. Like you kind of got to know diabetes and hypertension and blah, blah, blah. And I realized over the years of teaching, nothing teaches better than to do failure. If you can show that chronic progression of heart, and you can take any disease, they all end up in a common end pathway. So if you have the structure function and you have the core pathophysiology, you just plug in the disease that gets you there. So if you can do failure in every organ system, you can kind of teach yourself the rest. It was one of these really profound insights that snuck up on me. And so I would teach failure, and I would teach it patient-centered. So if you came to my Step 1 review course, 42 hours, I would start with a 68-year-old male presents with shortness of breath. and we're going to take that into congestive heart failure. It takes me 3 hours. If I'm starting with students that haven't done patient-centered learning, that will take me 3 hours as I build up all the structure function. Then I have to do the adaptation. Then we have to teach all the views. And then we have to walk through what happens in failure. So we need a pathophysiologic model. That takes 3 hours. For example, students can't do a short axis view. Well, there's no point in going on when you're talking about ischemia if you can't do a short axis view. So we have to start and talk about, okay, here's the heart. Now we're going to cut it right across like a loaf of bread. See it? Right? So here's my left anterior descending. Oh, where is it? Where is it? So you literally have to teach. It takes time. And there's no point in going on if you can't do it, because every picture they're going to test you on will be that donut with the arteries. Well, I sort of got this push for multiple choice questions. And I said, well, what if I just take my open page, discuss this patient, and I just make it a multiple choice question? Well, it turns out you can do that. And so if I have 3 questions on congestive heart failure, guess how long it takes me to teach them? Yeah, 3 hours. Because the first one starts with shortness of breath, what's the differential? And the last one ends with, so tell me about paroxysmal nocturnal dyspnea.
So these are high yield
Ideas.
multiple choice questions.
Ideas. Not facts. If you think you're going to come here and get the best facts, you're not. That doesn't exist. But if you want to know, how do you organize the complications of diabetes? That's one of my favorite things, right? Think how important that disease is. It's just, we're all fat. It's overwhelmingly important. And so you go, presentation, pathophys, natural history. Natural history is talking to the patient. And the first thing she'll say to you is, what happens to me? That's called prognosis. And then you say, well, what do we have to look for? That's called complications. And is there anything we can do about it? That's called treatment. So do you think it's fair to take one of the most important diseases in our culture and say, so what are the complications? You think that's fair? Could you imagine not being able to do that? Well, no one can. No one can, because no one's asked it that way in a clinical setting of presentation, pathophys, natural history. So this is what the students are always just astounded when I say. You ready? Well, there's acute and chronic, right? They go, whoa, that's true. Wow, do I know that? It's just, yeah, you only have to be told once. You only have to do it once. And then you have to teach them, when I say chronic, I only want 2 words, which is really fun, right? Who doesn't go, they throw out all the words. They go, no, wrong, you're all useless. No, and then I go, no, it's macrovascular, microvascular. What does that mean? And by the time they're finished, they're in love with diabetes, which is as someone who was writing step 2 said, and was finishing their residence said, that must be a third of all my questions of every exam I ever write is diabetes and its complications. So learn it once, learn it right, and a third of your problem in life has gone away.
If you guys liked this conversation, I'm going to be linking the full playlist of all the Dr. Tisdall Unfiltered videos that we have. But if you click here, this here is a video that Dr. Tisdall did on structure function. So if you want to dive a little deeper into that, this is the video for you. And Dr. Tisdall, we'll see you next time.
That was really fun, Allie. Talk to you soon.